I'm very happy to have two other very extraordinary, sorry, experts in that sense, according to, when it comes to access to medicine, with me anyway. So it's Bridget Sleep, who is the Senior Rights Policy Advisor at the NGO HelpAge International. And she focuses on strengthening the rights of older people through the use of human rights mechanisms. And Peter Jan van Eggermont, who's a humanitarian advisor for the Swedish section of MSF, Doctors Without Borders. And as Josette just said, the situation is sadly so that we are well known to both states and pharmaceutical companies that only 50% of the world's population are actually, the medicines and pharmaceutical companies are targeting only 50% of the population, and mainly in rich countries, the Western countries, the already developed countries. And there have been some attempts to find guidelines in the international arena to clarify and differentiate the responsibilities of states and non-state actors, including businesses, when it comes to human rights and health rights. And perhaps some of you know about the rugged principles, but it's not really clear how they actually will be adopted when it comes to pharmaceutical companies. So this is something that we will talk a little bit about. But essentially, we would be talking about the situation as it is today. Who has access to essential medicines today, and who has not? And in particular, we will look at low-income countries and a little bit about middle-income countries as well, because the situation is actually a little bit deteriorating also even in actually rich countries, but we'll focus on low-income countries. And I would ask Peter Jan van Eggermont to start this discussion today, because you've had a campaign within the Médecins Sans Frontières for 20 years regarding access to medicine. So we would love to hear a little bit more about that campaign and the fruits of it.
Thank you very much, and thanks for having me. I was actually thinking, since I work in Stockholm for MSF, to start showing a short movie. It's 5 minutes where some people, both working for my organization, but also some of our patients who are actually affected by this topic, will do the talking. So please, if you can start the movie.
Patients are dying, not because their diseases are incurable, but because as consumers, they do not provide a viable market for pharmaceutical products.
Medical science has made extraordinary advances to develop new medicines, new vaccines, and better tools to diagnose disease. But this progress has not been shared equally. MSF staff around the world continue to see people suffering and dying because they cannot access the life-saving medicines they desperately need.
The number of times I was told I was going to die was like 3 times. And the numbers of pills swallowed were like 20,000 to 30,000 tablets.
Tuberculosis is the deadliest infectious disease in the world. Pumeza was diagnosed in 2010 with its most severe form, called XDR-TB. Her treatment included a daily injection with toxic side effects that made her go deaf.
When I first met Pumeza, it was in a really tiny clinic in Kalicha. I remember feeling really shocked by the fact that she was deaf, and I just kept saying to her, I was like, so you can't hear anything, like nothing, and you were okay before. At the time, there were lots of people dying of XDR-TB. I mean, as soon as you got a diagnosis of XDR-TB, your chance of survival was less than 10%. So I felt quite hopeless.
At the time, no new TB drugs had been developed for around 50 years. Pharmaceutical corporations saw little profit in developing medicines for diseases that hit poor people the hardest.
If you get old drugs that make you deaf, blind, or disabled for life. I didn't understand what was that all about. Why are the scientists not making the drugs? It didn't make sense to me.
We got to a point with Pumeza where we thought the current treatment isn't working. We need something else. There was a drug called linezolid which potentially would help Pumeza, and so we tried our hardest to get hold of it. In order to obtain linezolid, you had to buy it privately through Pfizer. It was about 760 Rand per tablet at that time. That involved quite a cost for MSF.
This is not fair. It's a TB drug. It works. Fix the patent law so that the drugs can be available to everyone who needs it.
It took years of legal battles and street protests to get hold of the drug. Finally, the case was settled out of court. MSF was allowed to bring in generic linezolid from India for people with tuberculosis we were treating in Khayelitsha. In 2013, 3 years after her diagnosis, Pumeza was cured thanks to treatment with linezolid.
This was the moment that I decided I want to get involved, to get everyone a fair chance at life, to get everyone access to medication that is life-saving. I took it upon me to help other people who didn't have the stage I was given.
2 years later, a crowdfunding campaign paid for Pumeza's cochlear implant surgery to reverse the deafness the previous toxic treatments had caused.
Pumeza, I want you to have a chance to hear what your mom says.
With this implant, she was able to hear her mother's voice for the first time in 4 years. Pumeza's activism continues today in her local community in Khayelitsha and at national and international levels.
My name is Puma Cecilia. I was diagnosed with normal TB in 2010, while all along I had XDR TB. I ask you to act now. I asked you for change. My life changed. Now I can talk on behalf of other people who don't have a voice. I speak for them, and I think I'm very proud of that.
Starting all over again? I don't want to ask you to look at it twice, but I do hope you enjoyed the movie. There's literally tens of thousands of Pumeza in MSF projects around the world, and as a medical humanitarian organization, we have been working around 40 years in a variety of settings where this is a problem every day. I will briefly talk you through a bit more of the details, not only of the Access campaign, but also some issues that have been ongoing and where I really believe there can be done much more. So once again, thanks for having me here, and thanks for allowing me to present the MSF Access campaign. So Médecins Sans Frontières, or MSF, was created more than 4 decades ago. And around the late 90s, there was a lot of frustration and anger amongst our medical staff. I remember I myself started to work for the organization in the field in Angola, the early 2000s. And I remember attending an associative debate in Brussels where the MSF HIV treatment, which at the time was one of the deadliest infectious diseases in the world, was a lot of political controversies around the access to HIV treatment. And there was an increased anger. It happened to be that in 1999, MSF was awarded the Nobel Prize for our work. And the prize money, which I believe at the time was around $1 million US, I don't know what it is today, it's maybe something similar. But we actually used this money to try and address this problem. And the same year, the MSF Access campaign was created. The opening speech by our president at the time, you also saw a short excerpt from an acceptance speech for the Nobel Peace Prize, was very much what it's still about today. I don't think anyone at the time would have, let's say, guessed if we were going to continue for 20 years. It could be discussed whether something that's ongoing for 20 years should be called a campaign or not. But actually, when we see the issues still affecting us today, the story of Pumeza with drug-resistant tuberculosis in South Africa is a major public health disease where the lack of accessible treatment for young people, in spite of the scientific and the medical knowledge and the treatments being available, is an injustice which should be addressed by the community of concern. So I won't read the whole text, as one is not supposed to do with PowerPoints, but I think there's two elements here that I want to raise from the acceptance speech about why the need for increased access to treatment and medicines is such an issue. The first one is market failure. As I said, this is not an issue of lack of scientific knowledge. It's not an issue of lack of, let's say, technological possibilities to treat certain diseases. It's simply a failure of the existing market model and the research and development system backing it up. The last thing, and I'll try my best to guess a bit what our colleague Gunilla, who couldn't make it today due to illness, would say, but in essence, it's not about charity. It's not about, let's say, fixing the global aid budgets. Sweden is a very generous donor to a number of very valuable, very much life-saving global health solutions. But it's not about making your aid budgets 10 times bigger. It's about addressing the systematic mechanisms behind it. I'll come back to that. So I'm going to be talking about 4 aspects of this market failure. Don't worry, I didn't make it too technical, but please bear with me. At times I will be using a bit of more technical language about drug development. So first of all, diseases of the poor are not prioritized. People living in Stockholm Center, where I live, usually don't get affected by drug-resistant tuberculosis. Sometimes people coming from countries where this disease exists can have the disease, and it's being discovered here, but it's very rare, and it's not a problem. Like there's treatment available. So this is disproportionately affecting communities in poor countries, but as we will get back to, increasingly so in middle-income countries, where we also work. So for us, being a humanitarian organization is about helping out where there lacks a state or a government that is not willing or not able to take care of the humanitarian needs of the people residing in its territory. And this can sometimes be in middle-income countries too. It doesn't have to be conflicts or natural disasters. We work in a variety of countries where, for example, tuberculosis is a huge public health topic and not addressed. So I will talk a bit about which needs are ignored, and I will talk briefly about how the current scientific and financial resources for research are actually not being used in the most effective way. And a lot more could be done with the available resources. And I will also address the actual pricing issue. So, diseases of the poor. Some of you might remember 2014 when the Ebola crisis was ongoing in West Africa. It was not the first time Ebola occurred, and actually Médecins Sans Frontières have been working in the first, let's say, recorded outbreaks of Ebola and other hemorrhagic fevers since the 80s. Now, what happened in West Africa, in a number of countries that had weak health systems after civil wars in Liberia, Sierra Leone, these countries were simply not fit for taking care of the epidemiological consequences of a very, very dangerous infectious disease. Now, what happened was that in spite of several, let's say, research attempts since the 80s of developing both a vaccine for Ebola and a treatment for vaccine, these had never been developed up to the point of being available as a treatment. So the institutional response to the Ebola outbreak 2014 was disastrous. And as an organization, we've been really at the center of this, and several of my colleagues who themselves worked in our Ebola treatment centers at the time came home with shocking stories. So we called it a failure. As you might know, there's an Ebola outbreak ongoing right now in the eastern parts of the Democratic Republic of Congo. A lot of things have happened. So let's say this failure was very much present in 2014. Now there is a candidate vaccine, there is a candidate treatment, and we sometimes say a bit cynically, but things started to change when the first US citizen got Ebola. Then suddenly there was a mobilization and there was a lot of activity, both from the WHO, from the research companies, and we've been very much on the forefront. But I think it was a typical example where a disease that affects, let's say, a marginal group of people in a poor setting was simply not prioritized by the research community. This is another example which is fairly unknown. Snake bite envenoming affects over 100,000 people a year. That is more deadly victims than landmines in the world today. And almost 500,000 people are being handicapped or affected for their life because there are simply no available effective anti-venoms available. Very much the same thing. There is no interest from the research community, which means that often these are poor, a very typical example is seasonal workers. Poor people that travel from one region of, let's say, Eastern Africa or South Sudan is a very typical example. They go and work in the fields, they walk around bare feet, and they are affected by snake bites. Since there's no available antivenoms in these countries for the type of snakes that affect them, they go to traditional healers, ineffective. So this is really a huge issue that we've been talking about for a long time. Last year, this is very new, this is actually 2019, the WHO finally decided to officially categorize this as a neglected tropical disease. Not the type of disease one thinks of, but it's really a huge problem. Thirdly, and I think this will be in line with what Bridget will talk about a bit later, there's a number of diseases where certain patient groups are not prioritized by the research. One typical example is pediatric formulas of existing treatments. MSF has been treating HIV since the late 90s, as I said. We are still today addressing the lack of effective treatments for children with HIV, because the formulas existing are not specifically targeting them. Once again, there also because of the lack of commercial incentives to do so. And this is increasingly also an issue for certain rare diseases in this part of the world. Not so long time ago, there was a very mediatized case of a young girl with a rare disease in the Netherlands that couldn't get access to treatment because it was very expensive. MSF has started its own initiative to address some of these diseases. In 2003, we started a separate foundation called the Drugs for Neglected Diseases Initiative that has developed 8 treatments for diseases that affect relatively small communities in Central America, in Western Central Africa. It's diseases like Chagas disease, African sleeping sickness, the type of diseases one rarely hears about in the media, but they are, in the countries we work, a huge public health concern. All of these drugs that were developed by this foundation are very cheap. This is one of the goals we put up. It should not be dependent on the commercial value of a drug to develop it. So this has been done by open source research and a collaborative effort with a few public health institutions. Next problem. Certain vital public health needs are being ignored or not prioritized. And one huge issue that is currently gaining a lot of traction politically, not in the least in Sweden, the current Swedish government is very much engaged, is antibiotic resistance. There's a network based in Uppsala called REACT that is very active in addressing this issue. Basically, the main research companies are not investing in research for new antibiotics, and due to resistance developments of existing bacteria, the antibiotic tools we have are no longer effective. It has been called a threat to global health on par with climate change. This is really alarming, and there's a lot of worry that the few investments that exist are too small scale and not getting long-term funding to get them through. And this is really alarming. As I said, since 3 or 4 years, it's getting a lot of political traction. WHO is on it, but it's still a huge problem that there's no substantial research for new antibiotics. Yes, briefly. So basically what the established pharmaceutical companies are lacking for the moment is an effective use of our resources. And this is not only their own resources, there's quite a lot of taxpayers' public money going to research and development. So we sometimes say the consumer pays twice. You contribute with your tax money for supporting research programs in countries like Sweden. This is done, which is very good. But then we are also, I would say the health system is charged very high prices for certain of these products. So basically, you pay twice. There's an ineffective use of resources. We call it the multi-billion-dollar mistake, because research companies trying to protect their own commercial interests are basically working in silos. They are not sharing the results. What I mentioned with the Drugs for Neglected Diseases initiative, what has made it so successful in generating 8 available treatments in 15 years for rare diseases was exactly that is because of open source investment in research. All the failed attempts were available to everyone researching it. And then it goes much faster, it's much more effective. And what we see today is the opposite. So the major pharmaceutical companies, you saw Pfizer in the movie I showed in the beginning, they're not only drug developers, they are financial institutions. And if you look, they are very successful. I'm not putting a value judgments in their, let's say, ability to generate value for their shareholders, but there's a major misconception about drug developers being a philanthropic institution that is only there to research for the good. These are financial institutions, and if you look at, this is a breakdown we did, only 1 out of 10 of the biggest pharmaceutical companies in the world puts more money into research than it does in marketing. This is quite a mind-blowing picture, actually. So it should be the opposite, if you ask me. If you start from the point that development should be there to increase access to health, it should be the opposite, at least. One big issue is the lack of transparency. So pharmaceutical companies that charge very high prices for certain treatments, they say, well, developing a drug is very expensive. There's the failed attempts, there's the research plans, there's a lot of, let's say, complexity in developing a drug. Fair enough. The fact is, nobody knows exactly how much is being put in it because the numbers are simply not available. And this is also a thing that the MSF Access campaign has been fighting for since 20 years, basically. And also this year, so this is 2019, the World Health Assembly thanks to a lot of campaigning from civil society groups, MSF, others, patient groups like the ones you saw from South Africa and India, have actually managed to get a resolution being adopted at the World Health Assembly to demand price transparency and research cost transparency for drugs. This is groundbreaking. This is the first time in modern history that, at least now we'll see if the states, what they do with this resolution, but for the first time there is a formal commitment from the global community to actually force research companies to publish the cost for their research and the price of the product, why it is a certain level, and how much do different states pay. So we believe this is a positive step. Of course, the final resolution was watered down significantly, as it usually goes at that level, but it's a very important step. So unaffordable prices have been mentioned several times. Until 3 years ago, sovosbuvir for the treatment of hepatitis C, which is a disease that affects a lot of communities, not only in low-income countries, middle-income countries, but increasingly so, it's a problem for several European countries. Until a few years ago, if you take the price per gram, the drug was 67 times more expensive than pure gold. This is a very expensive product that even in Sweden led to rationalization of treatment. There's a hepatitis C patient association in Sweden that addressed exactly this problem. Another example is pneumonia. That is still one of the main killer diseases of children under 5 in the world today. There's a very effective vaccine, but it's being held by a monopoly of 2 companies producing it, and it's one of the world's most expensive vaccines. There is a financing mechanism. We will come back to this. Once again, I would have hoped our colleague from SIDA to be able to comment on this, but it's very expensive. So Swedish aid money is going to a financing mechanism for access to vaccines for poor countries called Gavi, the Global Alliance on Vaccines and Immunization. 1/3 of this Gavi budget is being eaten up by this one vaccine. To me, this should be an ethical debate. How much of aid budget should go to the profit of an established pharmaceutical company, which is one of the richest in the world? It shouldn't be like that. We think it is wrong. We have been campaigning about it, and yeah, we'll see if this continues. So one of the most effective ways of getting drug prices down is generic competition. You allow the market to be opened and to give room for cheaper produced copies of the same medication to be available. What we saw in the HIV crisis in the beginning of the year 2000 is, as soon as the markets was opened up, and this was a huge political controversy, there was a lot of lobbyism around. Some of you might know this, the TRIPS agreement, the Doha Declaration, and all these processes. Once they managed to break this deadlock and break the monopoly, the price dropped with 99% of a life-saving HIV treatment. And this was exactly the frustration that my colleagues at the time were talking about. They were basically treating people that were coming to the hospital in late stages of HIV/AIDS, dying in the waiting room. There's horrendous stories, and there was a treatment available, but it wasn't there because of the high price. India is a good example. It's been called the pharmacy of the poor. 97 of the medicines that MSF uses in our HIV treatment programs, we buy in India. And nowadays, we are allowed to do that. In the beginning, you had to break the law to import them to the countries where we treat it. So I won't get in too much, but this is basically one of the main, let's say, limiting factors, is that the drugs are being treated by patent laws that are, once again, developed by or used by pharmaceutical companies that are financial institutions. We have increasingly so started a fight against drug patents. Nowadays, we have our own campaign within the Access campaign where we actively ourselves do oppositions of existing patents. We file an opposition. We let the special courts that take care of these type of processes look into the science, because we have pharmacists who have a reason to question certain patents. that should be about protecting medical innovation and not protecting the commercial interests of very rich companies. Finally, and then I'm going to hand over to Bridget. So this is very much part of the Sustainable Development Goals. So goal number 3, the right to health, which these days will all be about, right? They contain language exactly about this. It's about neglected tropical diseases, AIDS, TB, malaria, hepatitis C. It's about supporting research and development of diseases that primarily affect developing countries, access to affordable medicines and vaccines, use the flexibilities in international trade law and patent law to make sure that you always put public health first, lives over profits, as it was said in the movie. So this is good, strong language, but unfortunately, as I hope became clear from my presentation, there's a lot of unsolved issues still ongoing in the world today. I will stop there. Thank you.
Can I just have a couple of follow-up questions, perhaps? And when you started the campaign 20 years ago, do you see a difference in needs today than 20 years ago? Would you say that there are some drugs that are more available, or and differently, are there new individuals or new geographic places that are more in need of essential medicines today? Is there any change in that?
The disease pattern where this is an issue, accessibility, has changed for sure. As I mentioned, the start of the campaign was very much the HIV crisis affecting sub-Saharan Africa. Certain countries had huge, and at the time it was a deadly disease. So this is no longer the case. Nowadays you can live a fairly comfortable life if you get access to treatment, which is the case due to the price drop mainly, and due to a number of, let's say, much more visible, much more political openness. Nowadays, you see more like tuberculosis is still a huge problem and not solved, and it's going in the wrong way. One other important trend that I think has been for the good was the establishment of what I already mentioned, these global health aid financing mechanisms like the Global Fund, Gavi. All of these occurred in the first half of the 2000s, and this has been a very important development. However, as I already mentioned, there's still an ethical discussion. How much of that money should be eaten up by the profit margins of pharmaceutical companies? To me, this is a real problem. Resistance has blown up, as I already mentioned. This is also new. And now there's a sense of panic that we're losing the tools to save lives in a very rapid development, and this is alarming. And unfortunately, the amount of genuine attempts to do something about it are very few. I think you can count them on one hand. So the language is there, the solution is not.
So when we talk about the pharmaceutical companies, are they state-owned, privately owned? Is there, or both?
Well, there's a few public-private partnerships, but majority, let's say, research is usually 1/3 public, 1/3 private. In a country like Sweden, it's interesting because there's a lot of small and middle, very innovative small companies that develop a product, but then it's being sold to one of the established big pharma there's no guarantee anymore for accessibility. So innovation is being subordinated to the profit margins. So I think we need the companies. You know, they have the capacity to produce that nobody else can. I don't think MSF could produce on that scale. So definitely, India has also, I think that has been a significant development. The pharmaceutical industry in India that can produce cheap, good quality drugs on a very large scale, that's a game changer. But unfortunately, in the international trade agreements, it's being blocked, and this is a constant fight. A few weeks ago, there was a controversy between the US and India exactly about this. The possibility for Indian drugs to be exported to other countries is still limited by a variety of trade measurements.
Is there a way of when you talk about patents, for how long a patent should be secured, and is that a discussion you have as well?
Yeah, definitely. So the problem with patents is that in its essence, you know, whether it's about an artist's protecting the song or the book that he or she wrote or composed, or it's let's say a developer of a pharmaceutical product. In a way, it's the same thing. They want to protect their innovation in order to be able to make a living out of it, right? Now, what we see instead is that the intellectual property laws, like patents, are systematically what we would call abused. There's a phenomenon called evergreening. It's a pharmaceutical company that takes an existing drug and they change a slight composition of the, for example, a liquid instead of a pill. And then they take a patent on that. It's the same product, but suddenly again, they secure their monopoly for 20 years. And this, we believe, is wrong. It shouldn't be about that. But the way the intellectual property legislation is being handled and formulated, it still allows companies to do that, and they have a very big legal departments with experts that know how to file the patents. So there's also a power imbalance there, which is very real, and these companies that I mentioned, these 10 biggest, are very powerful entities that can effectively block the development of cheaper alternatives.
And the drugs that are created from open sources, as you mentioned, are there any other sort of problems with that? I've mentioned security, for example, are the drugs that are sort of produced from open sources, are they completely safe?
Yeah, no. Well, I think nowadays this is not so much a debate. You know, this is an argument that has been used for many years, even before India took its place as a let's say, a serious generic contender. This was always the argument. Yeah, but India, you know, there's so much, and there are problems, obviously. But I think nowadays, with the set of normative frameworks for pharmacovigilance that the WHO runs, the WHO has 200 centers around the world for pharmacovigilance. So any, let's say, unexpected side effects or bad quality drugs are constantly being monitored, and nowadays also counterfeits. There's very excellent work being done. So I would say the risks in this are getting less. Of course, you can still have large-scale counterfeit. There's regular controversies with it. But I think it's a bit deviating from the actual discussion. Of course, you need both. MSF has their own pharmacists working all over the world, whether we buy the drug locally, if we buy it in India, if we buy it on the spot. For example, we can buy drugs in Kenya if there's a viable alternative and it's available. We will always do very rigorous quality controls, and it will be approved by our pharmaceutical division in Geneva, in the international office, before we use it. So I wouldn't say it's so much a practical problem. It's more used as an argument to block this development towards increased generic competition.
Okay. Thank you. We'll get back to you and questions. And it's a little bit difficult to see, but if there are any questions, wave your hands, and we'll try to save most of them for the end of the session.
That's good.
So I'll give the floor to you, Bridget, and I'll just introduce a little bit, say a few words about the aging population of the world, because according from data from the World Population Prospect in the 2019 revision, by 2050, 1 in 6 people in the world will be over 65 years old. And that's up from 1 in 11 in 2019. And 1 in 4 persons living in Europe and Northern America would be aged 65, or every 5 adults in developing countries will be over 60. So, and there are many factors determining whether older people are able to live healthy lives or not, of course. But one thing is clear, that with a population with this population growth, it also equates to increasing number of people who also require access to healthcare and services. Your organization, Bridget, work mainly in low-income, middle-income countries. And you have done a lot of research and talked and interviews with older people and record to see how they feel that their rights have been enjoyed. And when it comes to essential medicines in older people, can you give us some examples from the world, and also in general from your work, what it looks like? Are they available for older people or not?
Okay.
Thank you.
Thank you very much, Anna, and thank you. I wanted to start out by thanking you for inviting me to come and speak, particularly because older people's rights are very rarely addressed within by the international human rights community, and so to be able to come and speak about them at this event is fantastic. So thank you very much. So my name is Bridget, and I work for HelpAge International, which is a global network of organizations working on the rights of older people, including their right to health. And what I thought I would do for this presentation is focus in on one particular country, that of Tanzania, and to try and give you a flavor of what it's like for older people in Tanzania when they need to access different types of medications to address their health needs. And I wanted to also start by echoing Peter Jan's point about the importance of addressing the inequalities and the discrimination within health systems, and that looking at it from a systemic approach. And that's particularly important in terms of older people's right to health, because many health systems haven't kept pace with two very important developments or transitions. And one is around demographic change, which Anna talked about there, and how we are all living much longer lives, and populations themselves are getting older. As Sir Peter Marmot mentioned in the opening, there are often outrageous sort of inequalities within that when he talked about women living in poverty in the US and how their life expectancy was declining. But globally, life expectancies are rising, including in low and middle income countries. And at the same time, there's been an epidemiological transition where the pattern of illness is shifting towards non-communicable diseases. So diseases like heart disease, cancer, diabetes. And this particularly affects older people. Of the deaths, data from 2011, so it's a little bit old now, but 75% of all the deaths from non-communicable diseases, or NCDs, were amongst older people, people over the age of 60 in this particular data. And so what I'm going to look at now is very much around older people's access to the type of medication that they need to address some of their non-communicable diseases, or NCDs, that they're affected by. And Tanzania is a good example of this. In 2016, over a third of all deaths in Tanzania were from non-communicable diseases, and people over the age of 50 were disproportionately affected by this. But the government of Tanzania has quite a long commitment to health and people's health, and in the way this has sort of played out for older people is there are two ways that they have access to free medication and free healthcare services. One is through a fee exemption scheme, whereby anyone over the age of 60 is entitled to free health services, to treatment, to consultations, to medication in public health facilities. And this should cover all of the chronic conditions and the NCDs that they may be affected by. There's also a waiver for people living in poverty. And so this means that they can access free health services, as well as related costs such as transport or accommodation costs. So if they are referred to a hospital in a city center, they could also get their transport and their accommodation costs so that they could access that service. So in theory, at any rate, older people, people over the age of 60, and those living in poverty should have access to free medication when they need it. But as you can imagine, the reality is very different. And some of the barriers that I'm going to talk about, and this is based on some research that we have done, or research in the sense that older people themselves have done it. So one of the ways that we try to better understand people's enjoyment of their rights is through citizen monitoring. So older people themselves will go and visit other older people in their community and ask them the extent to which they have, in this case, access to medication and access to the health services that they need. Okay. And at this point also, it's probably useful to note that low-cost generic drugs to treat NCDs and chronic conditions are available. So it's slightly different to some of the other diseases that have been talked about, but low-cost generics are available. So the barriers that older people face, given that they have these exemptions and waivers, include not having a birth certificate to prove their age. And so if you don't have an identity card or a birth certificate that shows what age you are, you can't access that exemption or free medication. Poverty status is also hard to determine. And so again, even though it's guaranteed in law, this waiver that you could get if you were living in poverty, if you cannot prove your poverty status, then you cannot benefit from that scheme. And even if you can, the bureaucracy involved in getting your exemption card or a recommendation letter for your waiver, this can be an obstacle for many older people. Another barrier is around stigma and discrimination attached to these types of schemes. Older people have spoken about how when they go to health facilities and they want to access medication, that the health workers are often show very little motivation to administer the exemptions, or the health workers don't understand the schemes, or they may treat older people in a discriminatory or disrespectful way because of prejudices and stereotypes about older people and older age. Okay. And so amongst some 60 to 69-year-olds, 75% of them had to pay for their health services. So even though it's guaranteed in law that health services will be free for anyone over the age of 60, 75% of 60 to 69-year-olds are having to pay. And very often the only thing that is free for them is the consultation with a doctor, if in fact they can get to see a doctor. So in terms of access to medicines specifically, the way medicines are made available in Tanzania is twofold, through private wholesalers and also through the government. And private wholesalers will buy drugs and medication from international or from local manufacturers, and then they will distribute them through retail outlets, through drugstores and pharmacies and things like that. The government, on the other hand, has a medical department stores, and they're responsible for buying all the drugs on the essential medicines list. And they will then make those available in public health facilities only. So it's the drugs on the essential medicines list and in public health facilities only. They also provide them to some NGOs, to faith-based organizations, or other non-commercial, non-profit providers of healthcare. So we have this dual system of making drugs available. But very often, not all the medicines are available. And I just wanted to show you this photograph because I think this absolutely epitomizes the problem. The drugs cabinet that is absolutely full is, as you can imagine, through a private distributor. In fact, this is a police pharmacy. So the cabinet that's full. The cabinet that is virtually empty is from a public health facility. And so even though guaranteed in law, you have an essential medicines list, very often the medicines are just not available. Older people have told us that sometimes they would be given, they've been prescribed a drug, but then they would be given perhaps half or a quarter of their dose and not their full prescription, which clearly means that it will not be as effective as it would be if they had been given their full prescription. Often it's too far for older people to travel to the public health facilities, especially if they're referred to treatment in the city or in the capital. And so what happens is that they then have to buy their drugs from these private retailers, from pharmacies and drugstores, and then incur very high out-of-pocket payments, which they can very ill afford. In Tanzania, there is no universal non-contributory pension. In Zanzibar, there is a universal pension, but on the mainland in Tanzania, older people don't have access to a non-contributory pension. And the numbers who are in receipt of a contributory pension is very small, basically civil servants. But most older people in Tanzania don't have access to a pension, and so if you have to pay high amounts for your medication, this is prohibitive for very many older people. Another issue in terms of access to medicines is that older people are not being screened in the first place for non-communicable diseases. So for 50 to 64-year-olds, 2/3 of 50 to 64-year-olds hadn't been screened for high blood pressure. And in terms of testing for diabetes, 87% of 50 to 64-year-olds had not had a blood glucose test to see if they had diabetes. So if you're not screened for the condition in the first place, then obviously you're not going to be accessing the medication that you need. It's interesting that the data I'm giving you is only from 50 to 64-year-olds, and this is another systemic problem in terms of the data that is available when we reach older age. And although here in Tanzania, they did a survey on non-communicable diseases, which was fantastic to get the information that they need, but obviously they weren't including people over the age of 64. And so those people are invisible in the data as well. There's also inequalities in terms of where you live, whether you're likely to be screened for these conditions. So it's less likely if you live in a rural area. So 93% of older people in rural areas have never been tested for diabetes, compared to 69% in urban areas. Well, 69% is not being screened is completely unacceptable as well. But if you live in a rural area, then you are, virtually, 93%, virtually no one is being screened for diabetes. And then the final point I wanted to make around particular medications is around palliative care. Because we have found that when we've asked older people if they are aware of palliative care, and palliative care services, which include medication as well as other forms of palliative care, very often it's a concept that they have not even heard of. And whilst, of course, we can die at any point in our life course, death in older age is something that is very common for many of us, and as we live longer, we're more likely to die when we're older. And yet palliative care services and medication are virtually unavailable in contexts like Tanzania. And where palliative care is available, it's very often limited to one particular illness. It's usually limited to cancer. Sometimes people with HIV and AIDS have access to palliative care, and often it goes to people who are younger rather than to older people. And so many, many older people around the world are dying in unacceptable pain. And so this is another issue, I think, when we talk about access to medicines, is access to pain relief at the end stages of life. So what about the way forward? What can be done about this? Obviously, there needs to be a much greater awareness about older people's health and the conditions that affect them, much greater understanding, both amongst older people themselves, but also amongst healthcare workers. There needs to be training in geriatrics and older people's health, not only in medical schools for doctors, but also in nursing curriculum. There needs to be far greater attention to this. There also needs, in Tanzania in particular, there also needs to be greater awareness of the entitlements that are guaranteed in law, the exemption and the waiver fees. But that won't address the problem of supplies, and remember that empty and full drugs cabinet. And I think one of the things that the state has to do, and the Ministry of Health has to do, is firstly review its essential medicines list and make sure that the medications that are available, low-cost generics, are available to treat chronic conditions are not only on the essential medicines list, but are also available at all levels of the health system. So if people are only able to access their local primary health care or community-based health care facility, then that is where the drugs need to be available. It's no good having them in the hospital in Dar es Salaam if no one can get to it. So reviewing the essential medicines lists and then ensuring that they're available at all levels. A second thing that they need to do is monitor the supply system to ensure that there is a steady supply of these drugs to these lower level health facilities. And then if the drugs aren't available, then maybe there needs to be a voucher or a coupon system. So if I, as an older person, I go and I need my insulin because I have diabetes and it's not available at the public health clinic, then I could be given a voucher that I would take to a private drugstore and I would get it for free, and then the private company could then claim off the state, so that my right to health, my exemption from fees, which is guaranteed in law, can be respected, and I can enjoy that right. It's complex. The supply and demand is difficult, but there are certainly steps, I think, that can be taken that would increase older people's access to the medications that they need. And with that, I will stop. Thank you very much.
Just a follow-up question. I mean, you were talking a little bit about this. I mean, how much of this problem is due to resources or lack of resources, or prioritization of who gets the medicines, or even neglect? Can you see if what would the answer be? Is there what does the problem come from?
I think, I mean, if the problem stems in the essential drugs list, if the drugs are not on that the essential medicines list, then in the case of Tanzania and others, then the state is not going to prioritize them. It's not going to buy them and make them available. And so I think there does need to be a review of the pattern of illness in a country, and an essential medicines list needs to reflect that. It needs to meet the health needs of the population. And if it doesn't, then we have to ask questions about why. You know, why are you prioritizing one particular disease over others, when in fact the health status of your population looks like this. So I think there are definitely issues of prioritization, and whilst it's one thing that certainly our experiences from what older people tell us is that ageism and age discrimination is deeply, deeply entrenched in society, within us as individuals, and within systems, and health systems isn't exempt from that. And I think that a debate around ageism and age discrimination is needed, because that would also give visibility to some of the kind of a lens through which to look at some of these decisions about which drugs are made available and which aren't. I think that would be helpful.
Yes, and even if you've spoken about Tanzania, it's an example that is also a little bit general, in a problem that is more, you can see these this situation developing not only in developing countries, but also perhaps in other countries as well. The sort of how we look upon older people and their rights. Can you say a little bit about that? Can you see that there is a difference in attitude depending on where you live in the world?
I would say not. Obviously, there are differences in how discrimination or age discrimination is sort of manifested or plays out in high-income countries, middle and low-income countries. But from talking to older people in each of those, I think that there really is, there's a common experience of ageism, even though it might look slightly different or be played out differently. I think that unfortunately, it's at the moment, part of our sort of shared humanity, that this sort of very negative stereotypes and attitudes towards older people and towards older age itself, including to our own older age and ourselves as older people. And I think that it's experienced by older people everywhere, I think.
Please join us and let me know if there are any questions from the audience. Otherwise, we'll try to follow up on some questions related a little bit to state obligations, I would say, because you do work, and both of you from a human rights perspective and you as a humanitarian from a humanitarian organization, and try to affect states to solve the problem or at least recognize it. And how do you work in your organization? Is that through lobbying, or what kind of work do you do to make states aware of their obligations in this sense?
Yes, so we or the partners in our network and older people themselves do use advocacy and campaigning to try and change state behavior. And one of the ways that we do it, as I mentioned before, is through older citizens monitoring. And so when data is not available because there are age caps in data sets, you have to find an alternative means to finding data and evidence. And so we have found that, and particularly in this case, where older people themselves will be gathering data about their access to health services and access to medication and other rights as well. And then they use that data to influence at the sort of district, local district or national level. And so one of the things we would look at would be the essential medicines lists, and to see whether the drugs for the conditions that affect older people are on the essential medicines list. Or they might be looking at access to the availability of doctors or access to specialized care for those conditions.
And what about Doctors Without Borders? You work both towards the pharmaceutical companies and states.
Yes. So what I spoke about today is very much a campaign that was created to put focus on advocacy and raising the global awareness of the problem. In virtually all countries where we work, unless active conflict settings where there is an issue of, let's say, acceptance, be it by state or non-state actors engaged in the conflict, we always try to have a very clear focus on maintaining a good, healthy dialogue with mainly the Ministry of Health. We sometimes train national health staff, and this is very much about, implementing treatment protocols, changing them when they're not effective. So very much, I would say, in line with what you're doing. Obviously, this is more easy in a, let's say, a more stable setting than in Yemen when the bombs are falling around you. But definitely, so I would say we try to be much more than just the humanitarian cowboys coming in and treating without caring so much. I would say all of the normative frameworks that I mentioned from WHO, we have been actively engaged in trying to get the language as strong as possible in these processes. So that we also try to do. And then afterwards, trying to focus on accountability so that the governments, but it's not easy being a minister of health in a lot of these countries. I mean, it's much easier to you know, discuss your national defense budget or you know, investment of private sector. Usually health ministers, it's not an easy position. So asking for bigger budgets to address some of these issues is complex for them. So we try to support and where we can, but it's in a lot of settings where we work, this is not the easiest thing, of course.
I was also thinking about what you mentioned, that when we talked about rights, and there are immaterial rights as well, I mean, for researchers and for their work and for scientists, but you told us very, very clearly, it's actually when so little money goes to the research itself, and most of the profit goes to the owners, in a sense. How can we actually, what kind of language can we use in order to change that? Is it the human rights language, or is it from a humanitarian perspective? Or what would you think is the most fruitful way of approaching the issue in that sense? If profit is so important as it seems, even though they seem to be very much aware of the problem, how can we move forward? Is it through changes from the states? Sort of a roof on how much money you could profit from, how much you could profit from pharmaceuticals?
I don't believe it will be enough to have the language, because this is very much, as I showed with the SDG 3, the language is there. I think the problem is well known. I think there is a lack of political will to invest in alternative models. This is an issue, definitely. Things are evolving, but in a very slow pace. There is, however, no lack of interest in research for male baldness, obesitas. Like there's a lot of diseases that are being invested in. I'm not saying this is a bad thing, but it's out of balance when one zooms in at the more poorer populations in low-income countries and others. So yes, alternative models exist in theory, but they have to be gaining political support, and there has to be investments in them. And then the pharmaceutical companies can protect their business model, but we cannot continue to rely on this part of the private sector to solve the issue, because it's obviously not happening. We've been waiting for that for way too long.
Would you say?
I mean, I agree that the political will has to be there, but I also think that there is a huge value in standards and international standards. And whilst there are, you've mentioned a number, one area where there is a gap that could certainly help in terms of raising the visibility of older people's right to health is within international human rights law. And we were talking about this before, and that whilst older people are covered by generic, not generic, we're talking about generic medicines, but generic human rights standards, universal human rights standards that are applicable to all of us, and the very unique and particular circumstances of older age and the barriers that older people face to their rights haven't been addressed or haven't been looked at specifically within international human rights law. And I think that unpacking what the right to health means for older people and or for us when we are older and in older age, to highlight some of these issues around medication and access to it would, I think, help to certainly give visibility to the problems and some of the inequities and discrimination within health systems.
If there aren't any questions, I would like you, do we have a mic?
Do you want this one? I don't have to throw it at the...
And please also give us your name, perhaps. Okay.
Okay, my name is Suruchi Thapa-Burkut from Uppsala University. This is a question directed at the presentation on Tanzania. I think there are two qualifications I would like to make. First is that your presentation was very illuminating, but in developing countries, I think to put the onus on the state, that has to be problematized, because you have in developing countries both private hospitals as well as government hospitals. Poor people are normally accessing government hospitals. Often there is discrimination based on class, caste, religion, besides ageism. So I think that is one of the things. They are, of course, if you were to just take class, they don't have the means to access private hospitals. Those are very much for the middle and the upper middle classes. The second thing is that if we are taking the framework of human rights, then why don't we acknowledge that the current state, whether we are talking about the medical resources or we are talking about other kinds of resources, that the current state of these developing countries is precisely because of a Western hand in it. For example, the structural adjustment programs, which had a devastating effect on health, and a lot of countries which were structurally adjusted, starting from the 1980s, Tanzania being one, they have not recovered. So why don't we acknowledge that the Western world has also an onus towards these countries which were structurally adjusted by big financial institutions such as IMF and World Bank?
Thank you. Would anyone, it was directed to you primarily, but...
I certainly recognize your points. I think why put the onus shouldn't only be on the state. I think that when we are talking about human rights, the state has the main obligation, and so we do have to look at whether the state is respecting, protecting, and fulfilling the rights of all its citizens. So one thing that perhaps I didn't mention was around within that obligation is the obligation to ensure that non-state actors, such as private health providers, are also delivering their services in line with human rights standards. And so I do think that states have an obligation to make sure that service providers are compliant with human rights standards. So it isn't only the state that needs to comply with human rights standards.
Mm-hmm. And we could also mention something we had hoped to discuss with Gunilla from CEDA, who unfortunately isn't here with us because she's ill. How international cooperation is necessary also for fulfillment of, and also an obligation according to the Economic, Social, Cultural Rights Covenant, and how so states that are working with international cooperation and funding, they have an obligation also for other countries, not only for their own countries, in that sense. But we don't know, I'm not sure.
And I think that I mentioned earlier the need for international standards on the rights of older people. That too would include that international cooperation obligation. And that isn't only in terms of financial support, but also other types of support as well.
Yeah, absolutely. Would you like to say any comment on that?
I can try. So I think for us as a humanitarian agency, even though obviously a lot of the work we do, not in the least with the Access campaign, is about the right of individual patients to access the best possible attainable standard of health that they can have. Now, we are a bit, due to our principle-based approach, which includes a very strict and almost old-fashioned view on neutrality, we are careful to make our focus too explicitly state-centered. We don't center on anything else either, but in a way, in theory, it shouldn't make a difference whether it's a faith-based organization or a private clinic or a state hospital providing this access, as long as it's there and as long as it's, as you mentioned, according to a good standard of health. Now, when I mentioned earlier, before we started, that we don't work explicitly according to the human rights portfolio, I saw a bit of troubled look on your face when I said that. But this is exactly what it is. If we would, let's say, in a country like Yemen or Syria, where we have huge operations, if you there would start from a rights-based approach, you would simply end up in trouble when you're trying to work in rebel-controlled areas. So there is a point in not making these things too explicit and focusing on doing the job instead of advocating for the right to get the services. And this goes for all areas of work, and it's not only for the type of diseases I mentioned. It's the same with access to safe abortion care, which we provide in very complex settings sometimes. So there is a strategic choice to not start on top the state-based, state-centered human rights, international law agreements. Then when my colleagues in Geneva followed the WHA and all these, obviously that is where they start. They start with the legal language, they try to approach it via that, but let's say as a humanitarian medical agency, that is not our primary goal. It's to save lives and alleviate suffering. But both should be done, obviously, and there's excellent work being done by a number of organizations to cover the human rights part of things, and thereby very often focusing on what the state is doing and not doing.
I'm not sure that was answer to your question, but that's what we can give you today. Are there any other follow-up questions? Or not? So, if you want to have any closing words or to this, I'm just wanted to say we will talk about this tomorrow, because when we talk about international cooperation and also on perhaps also looking into whether ageism and also older people's rights could be a new instrument in the international community. How is that work processing? Do you think there will be a convention on older people's rights?
I am optimistic, yes, certainly. So for those of you who are unaware, there is a debate, a process at the moment going on about the possibility of new or international human rights standards on the rights of older people within a dedicated legal instrument. And that discussion is happening amongst member states at the UN, but also at the national level, because that is where governments decide their position. And so there is advocacy and campaigning and debate going on at national level around the world. And I think that the case is strong. As I mentioned earlier, older people's rights are at the moment virtually invisible within the human rights system. And what the process is showing is it's developing an understanding of how our rights apply when we are older, and looking at things that might change in our lives as we get older, and then how rights apply in that context. So, I mean, it's absolutely relevant and pertinent to the world we live in today, where we are all living longer. And so, yes, I'm optimistic that will result in a new instrument. Yeah, certainly.
Yep. Yes, so our time is not really up, but there's only 3 minutes left, but we will finish there, and I hope you have had a good 90 minutes with us, and thank you so much, Peter John, and Brigitte, for this session. Thank you so much.
Thanks.